his work has spanned from before he joined McCure, it was with the Medivation in the Lagos University Teaching Hospital. He's also been with Reddington at some point, been with Arrive Alive at some point, but right now his wealth of expertise has earned him the prestigious position of the radiologist for the entire in McCure, where he has been doing justice to analysis of both the MRI and the CT scans and also the ultrasound scans and all that. He's going to be coming with his wealth of knowledge to shed a whole lot of light on the cases that we've done concerning PET-CT. Dr. Drujaya Odeja would like to especially welcome you to this webinar.
Thank you very much, sir. It's an opportunity to be here. Thank you, sir.
You're welcome. So we'll hit the ground running by taking the very first presentation. It's going to be taken by Dr. Akinrunmi. Dr. Akinrunmi is going to be speaking to us concerning the role of PET-CT and an overview of PET-CT imaging. So, Dr. Akinrunmi, if you are ready, we are ready here.
Thank you so much. I am ready, Dr. Lolade. Once again, good afternoon, panelists and distinguished members of the medical community who have come to listen to this lecture. Some people have asked me, is it true that we now have PET in Nigeria? And I'm pleased to be part of this webinar talking about PET-CT imaging. I will just be taking an overview of PET imaging, touching on the basics, letting you know what to expect as physicians, especially physicians who will be sending their patients. Next slide, please. So PET stands for positron emission tomography, and it's a very sensitive test that shows both normal and abnormal physiology and biochemistry of the body. So it could be tissue specific or entire organs can be imaged with PET. And it usually comprises of a positron emitting radioisotope that releases the electrons or the photons that are imaged. And then that isotope is combined with a tracer. A tracer could be a biomolecule like water or sugar. It could be a neurotransmitter or a receptor that specific or selectively targets the organ of interest inside the body. So PET has not been available in Nigeria because it requires access to a cyclotron. And a cyclotron is a very technical piece of equipment. It's about the same severity in terms of standards with pharmaceutical production. So as a result, Nigeria just got into PET imaging recently, even though PET started way back almost 60 years ago, more than 60 years ago, when the first PET scanners were designed in the 60s. Around between 1991 and 1999, the idea of fusing PET and morphological imaging, specifically CT, came to light, and that helped to bring the best of both worlds. And in the year 2000, Time Magazine awarded PET-CT as the invention of the year. And from then, medical treatment has been, medical oncology diagnosis as we know it and treatment has been transformed. And the progression or development in PET-CT technology has continued. Now we have PET MRI, and recently there was the whole body PET scanner that does a PET scan in a matter of seconds. It's the Explorer. They're quite expensive equipment, but indeed PET is pushing the frontiers of medical imaging as we now know it. Next slide, please. So this picture just shows, explains all I have said. There's a positron emitting radionuclide. emits two photons that are released in opposite directions and are detected at the same time by a scanner. So the scanner is what detects it. The PET itself is not radioactive. It's the patient that is radioactive, but the CT component now makes it useful for localizing specifically where the emission happened. So there's something they call, the positron travels a short distance before it releases the photon. So because of that short distance, it affects the sensitivity of PET imaging, but the sensitivity is somewhere between 0.2 millimeters to objects smaller than that, maybe 2.4 millimeters. So it's a very sensitive and advanced technology that we use. Next slide, please. So why would anybody want to do a PET scan? PET is changing the way cancer is managed. For majority of cancers, PET is useful for primary staging, but more importantly, for most cancers, it can be used to assess the treatment response. That means that from giving the first or second course of chemo, one can predict or have an idea of the prognosis if the chemo is working or if there's a need to change the chemo to something else that works. And it's versatile for detecting disease recurrence. This is important because when tumor is detected, recurrence is detected early, one can do treatment early that prevents other complications or problems down the line. So this is why PET is so useful in oncology. But it's not just useful for oncology alone, it's also useful for cardiology, for brain imaging, and more recently has been applied for infectious or inflammatory diseases. Next slide, please. Next slide, please. So as I was saying, the PET scan is a versatile tool for oncology, but it's not just alone in oncology. For heart diseases, it can detect areas of hibernating myocardium, either when the cardiologist needs to know if the myocardium is still functional, where they can do some treatments to restore cardiac function, or where those treatments would not be useful and medical therapy can be used. PET is also important for diagnosing dementias. As a matter of fact, PET can detect dementias years in advance before symptoms occur. And so it just goes to show how sensitive it is. If the slides are back, we can move to the next slide. Otherwise, I'll just continue on this slide and hope that Dr. Lolade can get us to the next slide as quickly as possible. But in other infectious conditions, okay. So this table just shows some common PET tracers, and I'm trying to show the radioisotope as distinct entities that define the application for PET. So we have carbon-11, fluorine-18, gallium-68, nitrogen-13, rubidium, and the biocompounds are familiar things. Methionine is an amino acid that can be a marker or imaging marker for tumor protein synthesis. And we also know deoxyglucose, just like normal sugar, just that it's a marker of tumor metabolism. PSMA, there are other tracers that are not mentioned here. There's the fibroblast activation FAPI inhibitor that is gaining ground. So as these new tracers begin to evolve, the versatility of PET begins to come out. And in the future, we expect that more tracers will be designed for disease-specific causes. Just recently, a breast imaging PET tracer, FES, was approved by the FDA. And we expect that to also improve the diagnosis and staging of PET and breast cancer with PET. Next slide, please. So this just shows the similarity between glucose, that's normal glucose or sugar, and deoxyglucose. Basically, the carboxyl group is replaced by fluorine-18, and it's introduced into the body. So the fluorine 18 can be used to track this sugar as it moves. And it's important because FDG is the most commonly used tracer in the world. The chemistry of fluorine 18 is favorable. It's very small, so it's easy to attach, and it does not distort the normal function of the body. It has a suitable half-life of 110 minutes. And that half-life just means that it's the time it takes for the activity to reduce by half in terms of radioactive decay. And the mean positron range is about 0.2, but the maximum range is about 2.4 millimeters. So it's very sensitive, can detect disease to very thin, very precise levels. And the principle is simple. Normal glucose is taken up into the cells through the glucose transporters, that's the GLUT, glucose transporter receptors or channels, and is acted upon by hexokinase. Now, it goes into the TCA, that's tricarboxylic acid pathway, to produce energy. But with FDG, this step is truncated at just where hexokinase acts. So because of that, the glucose is trapped within the cell. Next slide, please. And effectively, cancer cells use more glucose than tumor cells or than normal cells. So you can distinguish metabolic signatures from abnormal cells, or between normal and abnormal cells. The preparation for the scan itself is straightforward. We need the patient to be fasted for 4 to 6 hours before the scan. We also need the patients not to be involved in any rigorous exercise. Even something as minute as long walks should be discouraged before the scan. We also tell the patients to wear loose-fitting or comfortable clothing. In fact, in some places, they will ask the patients to change into hospital clothing. Routinely, we check the blood sugar because the blood sugar levels can affect the quantification of the FDG. So, but we prefer for the blood sugar to be less than 150 milligrams per DL. Diabetic patients have special precautions. Those who are on insulin, those who are on metformin, have special preparation. So make sure to confirm before you send your patient. The injection is usually given intravenously, and there's an uptake time where the injection gets to spread within the body, and then the uptake in the actual cells happens. Usually the uptake time is about 60 minutes. And then we take a whole body imaging, which is something that's very unique about PET-CT. We don't take views like they do with X-ray or MRI, but you can do a whole body view, which is usually from the mid vertex or from the vertex to the mid thighs. It's about 15 minutes. So unlike MRI, there's no clicking sound. It's not as uncomfortable as the MRI. And then the imaging time is faster. So you need to prepare your patients by telling them they need to lie still for up to 15 minutes. With newer scanners, it's shorter. But 15 minutes is a decent time to prepare. Next slide, please. So this is what a normal FDG scan looks like. Remember, I said there will be uptake in normal and abnormal tissues. Now, these images just show the areas of normal tissue. The brain is an obligate user of glucose. So you can see that there's intense FDG activity. One is just a gray scale where the brain looks black. And then we have a color scale. There are several color scales, but I chose a gold or hot body color scale where the brain looks intense, like a golden yellow, bright yellow. But the uptake will vary between yellow and orange or red. Now, in a fasted state, the liver switches to glucose metabolism. So that will be like your normal baseline glucose uptake. So a tumor that's glucose dependent will take more than the liver. And that's how we identify tumor from normal cells that can take up FDG. Of course, there are special preparations whereby trained personnel can identify other things that can mimic tumor, which is beyond the scope of this lecture. But one should be mindful of normal physiological uptake in the brain, in the liver, in the heart muscles, and then the excretion that occurs in the urinary bladder. Majority of tumors use this glucose as their major form of energy production. And that's why FDG is highly sensitive for detecting those tumors. Next slide, please. So when you get a PET result, how is the result structured? It integrates both the morphologic and metabolic findings. So morphologic refer to the anatomical structure, which is given on CT scan, whereas the metabolic findings would refer to how much metabolism is occurring in the tissue or organ of interest. From the reporting doctor's side, we usually try to look for a single cause that explains all the findings. So most times we might offer new diagnosis. In fact, most times PET offers new diagnosis that was unknown previously. It's easy to just eyeball it from an expert's point of view. Dr. Sahin has done over 20,000 scans. So I'm sure if he wakes up in his sleep, he can see PET CT scans and give you a diagnosis. But some people expect that you give an SUV. Among nuclear medicine physicians, we call it that silly useless value because it really doesn't mean much. It's a semi-quantitative measurement of glucose uptake per volume of tissue. So there's no absolute SUV value that's a cutoff for most disease. It could work in some diseases, but it's just a good guide for comparison and could be used as a prognostic tool in several tumors. But what we focus on is the pattern of the metabolic signature. So any tumor or metabolic activity that is greater than liver is most likely to be abnormal. And we look at the symmetry. If it's symmetrical, it's most likely to be non-tumors because cancers are rarely symmetrical, but except it's diffuse lung metastasis. Most things are usually on one side if they're malignant. So we try and look for things that are common in different cancers, prostate, breast, and all that. And then for us to make a useful report, it's important that the referring doctor sends complete clinical information. As a practicing nuclear medicine physician, I usually just get a scan, just say bone scan, prostate cancer. It's really not helpful, and it's not going to be helpful for PET CT if we don't have the full details, because not every cancer takes up FDG. Sometimes the treatment can affect the pattern of uptake. So it's important if a patient had chemo recently, as opposed to a patient who had chemo a year ago. It's also important to provide previous imaging so we can give you the full benefit of the PET CT scan. Next slide, please. So FDG is very useful, but it doesn't work for every cancer. So there are some tumors, but generally the intensity of FDG uptake correlates with the tumor aggressiveness. To every rule, there's an exception. So some tumors are indolent, but they have very intense FDG uptake, like paragangliomas, fibroids, and things like that. So sometimes some physicians just overlook them, but you might be looking at something and say, oh, the doctor missed this, or why is he calling this benign? But there are tumors that have intense FDG uptake and are not malignant. There are also aggressive tumors that would not take up FDG, either because the tumor does not depend on aerobic glycolysis, or some tumors that are so aggressive they have alternative metabolic pathways that do not rely on FDG. Sometimes there are small lesions that FDG can miss, although it detects more lesions more than CT or MRI, but we could still miss lesions that are too small. So sometimes you have a patient who maybe has some tumor marker just slightly elevated and FDG is normal. We always say rely on the FDG for macroscopic disease. In terms of microscopic disease, it does have a limit to where FDG can detect, but it is still the best test out there for metabolic imaging. It's also very useful for staging after treatment. But if a patient has had the recent chemo, there might be a temporary switch off of metabolic activity. So we always want to know the history so that we can suspect if there's switch off or if it's truly a metabolic response to treatment. Next slide, please. So we've come to the end of the presentation. PET is vital for majority of cancers, not all of cancers, but majority of them. And how we prepare for the scan is very important. Preparing the patient, preparing the physician by sending adequate results is very important. And we should also bear in mind that it's not a panacea for all cancers. So not every metabolic abnormality is malignant, and not every malignant disease will show metabolic activity on a PET. And that's why the clinical information is very vital. I hope that with these remarks, I've been able to, in a short time, touch on the major things about PET-CT. And I'm sure whatever I missed, my other colleagues would do justice to that. So thank you for listening. I've come to the end of my session.
Dr. Rami, I want to say a big thank you to you. I see some hands are raised and there's some comments in the chat box, but I want everyone to be aware that we want to take all the questions together, so and all the presentations as well together. So I'm just going to go ahead now while we are expecting Dr. Adeuja, are you able to share your screen now? Want you to be able to, please, while that's going on, we want to appreciate our over 100 members. Yes, Dr. Adeuja is ready for us now. So Dr. Adeuja, we can allow you to have the floor. He will be speaking to us on transformative influence of PET-CT over conventional approaches. As I said earlier, Dr. Adeuja is a consultant radiologist, is a fellow of the West African College of Surgeons. Dr. Adeuja, you have the floor right now. Thank you.
Okay, thank you. Thank you very much. Good afternoon to everybody, or good evening, depending on where you are. I'll be reviewing essentially about 2 cases. The aim is just to create an awareness and an enlightenment of what PET-CT is all about, and essentially the importance of what PET-CT is. So the first case I'll be looking at is DSP, a 62-year-old female that was managed for colonic cancer with lung mets. She had colectomy, and she also had a previous CT with the index PET-CT that she had at our center, which showed no evidence of local residue or recurrence. These are the lung images demonstrating a nodule in the left upper lobe, just periphyseal, if you can appreciate this. And with the PET, we're able to see this hypermetabolic nodule, which confirms what we saw on the CT. Again, we saw these metabolic changes in the region of the mediastinum of the PET images only. And going to the next image, with the fused image to our left, which is this, it also demonstrates this, and also this area of the hypermetabolism. Now, if we come to this CT image only, despite the fact that we gave contrast, it was moderately enhancing at this region. This is the segment 4R, a right lower paratracheal node, which is moderately enhancing. However, the paraoesophageal node, a station 8, didn't really enhance. However, the fused image demonstrated it very well. So this shows an advantage that the PET-CT offers, especially when you are looking at the CT image and you're not specifically exactly sure if there is really a suspicious lesion. This brings it out. This is also a hypermetabolic nodule that we saw in the earlier image. So these are the coronal images of the same patient, showing those long nodes. This is a fused image to our left, and these are just long window CT images. We can appreciate the nodule, this peripheral one to the right lower lobe. We can also see this. which are being demonstrated as areas of hypermetabolic changes, even in the region of the mediastinum. So PET helps to further confirm whatever diagnosis, it improves our diagnostic accuracy and, improves the efficiency of our results whenever we need to do a PET and we are looking at the images, comparing and be sure of what we are seeing. There was an incidental finding in this particular patient. The image to our left, okay, so the image to our left demonstrates this nodule in the region of the left thyroid lobe. It's so small, so it's hypodense, as it were. So ordinarily one could have missed it in the scale of things, but luckily the fifth image showed that lighting up, very clear, conspicuous demonstration. And I had to go back to check the nodule again. Despite that he appeared almost insignificant. So I spotted it and I was able to notify the physicians in the report. And we were able to notify, sorry, not I now, but we, because the combination of the nuclear physician and the radiologist in reporting PET-CTs. So we're able to notify the referring physician, and we recommended an image-guided FNAC for this patient. This is just the PET image only, showing that area of increased uptake of the FDG, and this is the corresponding area on the contrast CT image at level of the left thyroid lobe. So going back to this tells us that, okay, PET also has an extra advantage in helping to pick incidental findings. So we're not sure if this patient had a synchronous, a metachronous lesion, as it were, but at least in flagging it, if the FNAC comes out malignant, then of course it will help in expediting management before it begins to spread and cause lytic lesions to the cervical nodes or the closest line of nodes in that region. This is the coronal images as I earlier depicted. Now, we also saw that in the woman's anterior chest wall, she had these ephysematous changes in the region of the breast. We were not sure because we were not given any history, so we were not sure of whatever possibility it was. However, we had to now compare with the fused image of the PET-CT, and we found out that, okay, it was ametabolic, no areas of increased FDG uptake. So we noted it as emphysematous changes. However, there was nothing suspicious in that region. The take-home point for this first case is that, one, PET-CT helps in doubling the diagnostic quality of the images, as demonstrated with the mediastinal and the mediastinal and the lung nodules. So we are sure, despite seeing it here, we are sure that yes, these things are still active. Sometimes, if the patient has undergone chemotherapy, radiotherapy, some of them might become inactive or less active, as we were, and the degree of enhancement will begin to reduce, and the physicians, the nuclear physicians, begin to look at the SUV values and the tumor to blood pool or tumor to liver ratios, in being more specific or more circumspect about the degree of activity or inactivity, as it were. Another take-home point is that apart from improving the diagnostic quality, apart from doubling it, it also improves specificity. Essentially, if you look at the images to our right, we saw this area of emphysematous changes like I earlier depicted. And because there was no area of increased uptake, we were sure that yes, this was just benign and not malignant. Again, it also helps in early identification of suspicious incidental findings. Like that left thyroid nodule that we saw was an incidental finding, because what the patient came for, well, the history that we were given was colonic CA with lung mets. So, and upon seeing this raised another index of suspicion that warranted further follow-up. The second case I would like to review is SSU, a 55-year-old woman who had done CT, contrast enhanced CT, with diagnosis of complex ovarian masses and a suspicious left breast mass. So the images to our left is an axial cut of the pelvis, a CT image of an axial cut of the pelvis, demonstrating enhancement of both ovaries. This is the right ovary, and this is the region of the left ovary. These areas of, this is fluid collection ascites within the pelvis. This is the iliac bone, the left iliac bone, right iliac bone, the sacral bone, and these are blood vessels, the internal iliac arteries now. Now, looking at the PET image only, we can appreciate areas of increased uptake being demonstrated in this region. So this tells us that yes, there's a malignant lesion, especially after calculating the SUV and the ratios, show that okay, this is malignant in keeping with the CT findings. Now, these are fused images, just simply demonstrating areas of very high uptake. These are FDG, FDG, they have high FDG ability, which we can appreciate in this region. And also here, this is, however, the urinary bladder. The urinary bladder to also physiologically excrete the radio tracer. So in this case, we are not so surprised seeing that. However, there's this area of moderate increase in uptake in the retroperitoneal region. And upon further evaluation, I would come to that. Now, if you look at this CT image, this is the liver. This is the stomach that contains fluid. This is ascites. This is the kidney just popping up, and this is the spleen. Now, this is my area of interest. If you come to this PET-only image, we can appreciate this area of high FDG ability. And it is just, almost non-existent, as it were, because it's just a small area of hypodensity. On the CT, which is to our left, we can see this area of increased density, hyperdensity taking up contrast, and it's something that could have been missed ordinarily because of the small and near inconspicuous size. However, the PET-CT demonstrated it. The PET-only image demonstrated it. And upon fusing the PET with the CT, it lighted up, became very clear, very conspicuous. And yes, we were sure that this woman had peritoneal carcinomatosis as a result of the bilateral ovarian lesion. Also, these are coronal images, and we can still appreciate this area that is almost non-existent or appearing almost non-existent in this region. One of the advantages that we must have seen so far is that the fused images helps both the nuclear physician and the radiologist in being specific and being accurate or being more confident. And even for the referring physicians, it will also help. And of course, there's an overall advantage to the patient, especially when we can pick this and document it, as it helps the further management and follow-up. This is an axial image, the CT only, and this is the fused image. Now, if you come to this CT image, this is the pancreas. This is the stomach, like I earlier mentioned, containing fluid. This is the spleen and the pancreas. In this region, ordinarily it should be fat. This is what normal fat should look like. This area of hypodensity or blackness, if I can use that word. This is another area of blackness that should just be fat. Now, if you come here, this is a bit fat. a bit fatty. But by the time we get to this place, we see that we can see some soft tissue nodules in this region. And they appear as if they are nodes. They are pancreatic and gastrosplenic nodes in that same region. Upon looking at the PET area, yes, it confirmed our initial suspicion. We can see areas of increased uptake. And in this region of the peripancreatic area, I also appreciate this, despite the fact that this is appearing hazy and not so specific. This is another peritoneal lesion, so small, almost sub-centimetric, and with moderate enhancement, which is, however, demonstrating increased uptake. as you can appreciate, on the fused image to our right. Another image. Now, for the same patient, like I said, if you remember in the issue, we said there was a suspicious left breast mass. So this is the breast mass in the left, just adjacent the glandular tissue. It is oval, homogeneous in density. And looking at the fused image, you can also appreciate that area of uptake, the central uptake that is demonstrating. So for this, we recommended an ultrasound-guided biopsy for the patient. There is this also, if you go back to the CT image, you can appreciate this area of differential hypodensity in the right upper paratracheal region, essentially a 2R node, which is also showing almost a golden yellow color, indicative of a suspicious paratracheal node in that region. And the advantage with this is that it also picks incidental lesions, and we can also recommend follow-up. In this particular patient, we found out that the axilla, these are the coronal images, CT, and the fused images, essentially PET and CT being fused together. We can appreciate that despite seeing the nodule, the mass in the left breast, the axilla is clear. It's essentially fatty the way it should be. Some of these are vessels, some of these are glandular tissue, no nodes. So it means that maybe this is a benign lesion, a fibroadenoma, or maybe it's actually a malignant lesion, cancerous. However, it had not started sending metastatic deposits to the axilla. So let's assume that it is a metastatic, it's a malignant lesion, and it's being taken off via mastectomy. So the patient, of course, would enjoy that opportunity of it being detected early and, being free from having to do some repeat CTs, looking for supraclavicular, internal mammary, or axillary nodes. So this gives an advantage also, especially when we spot incidental findings, and we can make recommendations as to how patients can be further managed. Now, this is an interesting case. Same patient. If we look at it, this is a CT image, and this is a PET-only image. If you look carefully and critically at this, we can appreciate the liver is homogeneous with smooth outline. These are areas of the portal veins taking up contrast. Now, if you come to the ligamentum venosum, almost looking normal as if there was no lesion. Now, coming to the PET-only image, you can appreciate this area of moderate FDG uptake. And this in itself was a bit suspicious for me. If I had looked at the CT only, most likely I might have missed it. And but with the advantage of the PET CT, I was able to pick it. And we were able to pick it and demonstrate it. And if you look at the fused image, it shows that moderate degree of FDG ability, despite the fact that if you come to the area of that same area in the region of the ligamentum venosum, is almost non-existent. So one of the advantages that this gives is that even in areas that look apparently normal, you can't be too sure, and you can't be over careful, by just ignoring what the fused image would appear like. So you were able to spot this as a metastatic hepatic lesion. Also, if you look at this is another level of cut of the same patient. This is the liver. This is the region of the falciform ligament. There is this moderate, vaguely appearing hypodense lesion. And this also might be missed if one is not extremely careful. But looking at the PET image only, it was able to demonstrate that area of increased FDG uptake. And we raised concerns for this. And upon looking at the fused image, it appeared very bright. It was highly FDG uptake. The SUV value was very high. And we are sure that, yeah, this is a metastatic lesion. Despite the fact that on the CT only image, one might have missed it. What the important point here is that the fused images and even PET images usually they help, in picking those subtle areas that one might have missed. So this takes me back to, years that we never had PET CTs and patients were being managed. I can only imagine how many cases, all these subtle metastatic lesions that we might have missed. Because this would also help. For example, if the patient is doing a follow-up PET CT, we can now begin to say, okay, we can quantify this and say, yes, there's disease regression or disease progression, or there's just disease stability. The take-home points in this case also will include incidental findings of breast lesions, of a left breast lesion in this index case, which is something that can be followed up, or we recommended follow-up. Again, it also helps in improving the diagnostic precision, like I said. The metastatic adenopathy that we saw, especially these ones that we saw in the gastrosplenic regions, these, yes. So these ones that we saw in this area, it improved our precision, and we're able to say that, yes, these things are existent, they are there. The peritoneal carcinomatosis that was even subtle and just broad-based, attaching to the peritoneal wall, we're able to say that, yes, this is also there, which might have been missed because of how small and how not brilliantly enhancing it was at the time of investigation. So apart from improving the diagnostic precision, we can also, the third one in this particular case will be that there's increased sensitivity of PET-CT, as it were, to ordinary CT alone, because of those equivocal liver nodules. For example, if you look at this case, in the region of the falciform ligament, one might have said there was nothing or not really. One might have not been too sure, but looking at the fused image, it was clear cut and it's visible for everyone to see. And looking at these two, in this region of the ligamentum venosus, almost non-existent. It looked normal, nothing wrong, but there was this area of moderate uptake. And by the time we calculated the SUV value, we saw that it was very much different compared to the baseline uptake of the liver. I want to thank everybody for listening. I hope it's been beneficial. Thank you very much.
Thank you very much, Dr. Dojaya Oja. We've been we're very grateful and we're glad that you've done justice to the case studies that we have seen. Thank you, thank you, thank you, and thank you very much. I know there have been questions, and like I said earlier, we will be taking all the questions after the last presentation. We don't intend to keep all of us here for too long, and we already planned that, as you would have noticed, each of the lectures is about 15 minutes, thereabout, plus or minus 1 or 2 minutes. In the same way, we would be requesting Dr. Sanchin, who presently is in Mumbai, to run us through his slides as well. I have the slides here. If he's ready, his slide. Dr. Sanchin, are you there?
Yeah, yes, I'm there.
Good. You can proceed now.
Can I get access to the PPT so that I can change the slides, or I'll just talk and you will do the changing slides?
Oh, well, which you let them give you ability to share the slides so that you could have control.
Yeah, thank you so much.
Beautiful. Yeah. But while that is being done, you can continue to speak so that I don't keep people waiting.
Okay. So I'm in.
Next slide. Can I go to the next slide? While that's being sorted,
I'll just summarize what my previous speakers have just now said, Dr. Akin and Dr. Aduja. Let me just congratulate both of them that they gave very good presentation, very brief and extremely precise, highlighting the importance of PET-CT. Now, just coming to what is PET-CT, I mean, already it has been told, but I'll just summarize. CT and MRI it shows the anatomy or the outline, the structural imaging, while PET shows the physiology or the day-to-day function, or called as functional imaging. So when we put both things together, we get form and function in harmony, and which is the gold standard at present in cancer imaging. Next slide, please. Next slide. Am I audible? This is a whole body, full body CT scan image. Next slide. This is a PET scan. Now we can see the difference. The CT scan shows very well the structural outline, while the PET scan, it is devoid of any structural outline. So when you can't have a PET only imaging and report, so we need a fusion imaging. Next slide, please. This is PET. Next slide. This is CT. I mean, this is the PET. And next slide. So this is how it looks. The CT scan plus the PET scan together forming the fusion image called the PET CT image on the right side. Next slide, please. So just to say that what PET, there has been a consensus that with PET replace CT or MRI. I would definitely say no. Both are equally important. So PET just complements the structural imaging like CT or MRI. Next slide, please. I'll skip this slide. It's already been discussed. Now, just go back to the previous slide, please. Now, yeah, why we use FDG? I'm focusing primarily on the workhorse of PET CT, the molecule which is used widely across the globe. It's called fluorodeoxyglucose, or in short form called FDG, which all the listeners would be reading it in a lot of PET scan reports. It's the short form of fluorodeoxyglucose, or it's a glucose substrate. Why we use? Because almost every cells in the body, they use glucose for their survival and growth, multiplication. Similarly, the malignant cells, the cancer cells, also use the same substrate for their growth and expansion. So, but they use this glucose on a much higher rate compared to the normal cells, and that is how we pick them up using FDG PET scan. Next slide, please. These are the certain cancers where PET CT makes a definite impact. Of course, I mean, there are certain cancers which Dr. Akin also mentioned that which may not be very much evident on PET scan, but yes, majority of the cancers, it will help. And these are few of those which are enumerated in front of you: lymphoma, lung, head and neck cancers, breast cancers, genitourinary cancers, liver, pancreas, and the gender specific cancers like ovaries, prostate, bone cancers, and also where there is a metastasis from an unknown primary. There, PET scan makes a major impact. Next slide, please. There are certain non-cancer indications of PET which are already been highlighted. I'll skip this slide. Next slide, please. Coming to the indications, there are multiple indications. Like first is pre-treatment evaluation called staging. Next, restaging after initial treatment is done, like surgery or chemotherapy or radiation, to decide upon the further treatment strategies. Next slide. The best of the indication is to assess response to treatment, which no other modality can offer. Also, it can be used on a regular follow-up, like on an annual basis after the treatment is completed, where the patient is, just in the initial maybe 4 or 5 years after the treatment is completed, you can do PET scan on an annual basis just to see or pick up early recurrence or asymptomatic lesion somewhere hidden in the body. Next slide. Majority of the radiation oncologists use PET scan before they offer definitive radiotherapy, radiation to the patient, to see if there is any sort of metastasis or any metabolically active lesion out of the field of radiation. Then the last indication is to differentiate between recurrence versus post-treatment changes. Now, this is again one of the best indications where no other modality, not even CT or MR, can help, because the changes which are seen on MR or CT scan, they are misleading, and there have been instances of over-reporting or calling post-treatment changes as disease recurrence, where PET CT definitely gives you a definite, gives you a definite answer whether it is recurrence or it is post-treatment change. And last but not the least, though not used very widely, the PET CT can also be used to guide biopsies. Now we know that the FNACs or biopsies, they do have a lot of inconclusive or inadequate sample results, but PET CT can help targeting the most metabolically active site, so that the biopsy or the FNAC gives you the desired information. Coming to the patient information, I in my department use minimum of 4 hours fasting or overnight fasting. I allow patients to have water, just the plain water. The blood glucose is checked before the procedure is started. We have serum creatinines, recent creatinines done, preferably in the last 1 month if we are using CT contrast. If the patient is diabetic, I ensure that the sugar is below 200, and the patients do not take diabetic medicines on the day of the procedure. Now, coming to the most important part of the PET scan, when to schedule it. Normally, the scan is scheduled approximately 6 weeks after surgery or chemotherapy, and around 12 to 12 weeks after radiation therapy, to avoid overlapping post-treatment changes. In my department, the scans are usually done in the morning because that's when the FDG, the radio tracer, is available to us. When the patient arrives, the patient is made to change into comfortable hospital clothes. Then IV line is secured. FDG is injected through the IV cannula. Oral contrast is started after a waiting period of about 45 minutes to 1 hour in an isolation room. The patient is taken up for scanning, which the scanning time differs between 20 to 30 minutes, depending on the compliance of the patient and the region of interest to be scanned. At all required, we need to also undertake delayed scans, especially when there are cancers of urinary bladder, because initial scans will show a lot of normal urine excretion of the radioisotope, and makes it practically impossible to locate the bladder tumor, or if there is a tumor which is not so very positive on the PET scan, we can also do a delayed imaging in such cases, so that the background, we allow the background to clear much better, so that the cancer gets highlighted easily. So around roughly the time of the total time from the arrival of the patient to the completion of the scan varies between 2 to 4 hours. Next slide. There are no contraindication except pregnancy. There are no side effects, at least I have not encountered in my 15 years practice, and there are no obvious documented side effects of only PET scan, the radioisotope called FDG, in literature. And the beauty of the PET scan is that it can be done irrespective of the serum creatinine levels. If the serum creatinine levels are high, we do a non-contrast PET scan. If it is not within the range, we can do a contrast PET scan. But there is no contraindication of doing a PET scan if the creatinine is raised. This is the normal biodistribution, which has already been highlighted. Coming to the next slide. I'll show certain images but just to highlight how PET scan helps. Coming to the first staging and prognostication. This was a case of a 74-year male carcinoma right breast. It was a non-metastatic, and PET scan confirmed that the lesion was only confined to the right breast. So the patient had a good prognosis, no metastasis at all. Next slide, please. This is a case of CL lung, metastatic, widely metastatic, poor prognosis, but PET scan, doing a PET scan helps you to accurately map the disease burden in the body, and that helps you to do an accurate response assessment after the treatment is offered. Next slide, please. This is a case of non-Hodgkin's lymphoma who came for a staging evaluation. It showed adenopathy right from neck, axilla, mediastinum, abdomen, pelvis, and inguinal region, and also involvement of the spleen. So accurate staging is what is offered by PET scan. Next slide, please. This is a case of CA right breast pre-treatment. Now the highlight of this scan is that the patient had a right breast lesion and a necrotic right axillary node. But what PET scan picked up was a right internal mammary node, which would have been impossible to highlight on a normal non-PET CT scan. It would have been easily missed. So definitely, though it does not change the stage of the disease, but for giving the right, offering the right treatment to the patient, it makes a major impact. Next slide, please. This was a case diagnosed outside as multiple myeloma, and the patient was referred to us for doing a PET scan to see the extent of multiple myeloma. We did a PET scan and we picked up a lot of nodes in the supraclavicular, upper abdomen, mediastinum, axilla. We picked up some certain liver lesions also, and also some marrow lesions. But once I did the PET scan, I was pretty sure that this was not a multiple myeloma. And I told the referring doctor that the imaging PET CT is not conclusive for multiple myeloma, but rather for a lymphoma, and a biopsy performed showed that it was a lymphoplasmoblastic lymphoma, which is a high-grade lymphoma. Next slide, please. This was a case of for pre-treatment evaluation of NHL diffuse large B-cell lymphoma, and it was a very much localized disease in the oropharynx with some neck nodes, but nothing other than the neck. No other disease. This was a case again of a pre-treatment evaluation after biopsy coming for a whole body PET scan. It was a case of follicular NHL grade 1 or 2. But after the PET scan, of course, we couldn't repeat the biopsy because already it was done. But after the PET scan, the SUVs were more than 10 at majority of the sites. And unfortunately, the biopsy was taken from a retroperitoneal node, where the uptake was, you can see that there is a node, retroperitoneal para-aortic node, which hardly showed uptake. But the rest of the nodes, like neck nodes or the mediastinal nodes, they were showing very intense uptake. So it was the take-home message here is that if you are suspecting a lymphoma or a disease which is which you are planning to take a biopsy from, you should first undertake a PET scan and target the most accessible and the most the highest SUV site, so that you get the accurate grading of the tumor. You can get the aggressiveness, judge the aggressiveness of the tumor. Next slide. Coming to restaging, this was a case of incidentally detected squamous cell carcinoma of the perianal region. It was the patient presented as a perianal granuloma, which was excised, and the patient then came for a PET scan. She was a 75-year-old female, and there was nothing in the local area because it was excised. There were few, next slide, there were few inguinal nodes. And next slide. but they were reported as reactive and the patient did not undergo any further surgery or any further treatment. On follow-up, the patient was completely asymptomatic and the PET scan was negative and the disease was under control. This is another case of carcinoma right breast. The patient had an inner quadrant mass. The patient underwent for an MRM and the patient then came for a restaging, post-surgery restaging. And we picked up a small right internal mammary node. Now, the dilemma here is that the patient came after surgery. Now, this node can very well either be a metastatic node or it can very well be just a reactive or an inflammatory node. Now, this is where the, PET scan can get foxed where the pre-treatment imaging is not in the right or the appropriate pre-treatment imaging is not done. This is a case of carcinoma penis after post-surgery and post-CTRT. This was a follow-up case that there were no reports available. Patient just came for a metastatic workup and we picked up bilateral inguinal and right external iliac nodes, which turned out to be metastatic. And the patient was absolutely asymptomatic in this case. This is how PET scan helps you to guide about the disease recurrence or whether what the status of the disease in your body. Next, coming to post-treatment versus recurrence. This was a case of carcinoma left breast, post-surgery and RT. The patient presented with some swelling in the cheek. A PET scan was done, which did not show any recurrence anywhere, neither local, neither regional or any distant metastasis. This was a case of CA buccal mucosa, post-surgery and RT, now presenting with trismus and PET scan clearly showing that there is a recurrence in the buccal mucosa now involving even the tongue. Coming to recurrence case discussions. This is a case of 83-year female operated for bilateral breast, carcinoma breast, and now presented with just a low backache. And the PET scan, you can see now the MIP image. Also, there are multiple hot spots. And on the cross section, there were nodes, there were nodal masses infiltrating the sternum. Next slide. There were mediastinal nodes, there were liver deposits, there were bone metastasis. Next slide. This was a case of Hodgkin's lymphoma, post chemo and radiation. This was a very old case. And now the patient came just for a follow-up and we picked up, next slide, a few nodes in the neck, but a prominent node in the right prevascular mediastinal space. Next slide. So that was a case of early disease recurrence in an asymptomatic case. Coming to the partial treatment response evaluation. This was a case of CA oropharynx, no previous PET CT imaging available. After the NACT, the patient came to us and we picked up that there is still sufficient disease left in the oropharynx, but no other distant metastasis. Next slide. This is a case of NHL, the diffuse large B-cell lymphoma after 2 cycles of chemotherapy for an interim evaluation. And we picked up that there is quite a bit of residual disease still left with a lot of post-treatment sclerotic changes in the bones. Next slide. Case of carcinoma right breast with node and muscle deposits post neoadjuvant chemotherapy. Next slide. The disease definitely has regressed compared to the baseline. Next slide. Next slide, please. So, but there is still a sufficient disease still left behind. Next slide. This was a case of glioma after treatment, and the PET scan clearly showed that though the lesion has significantly regressed, there is still quite a bit of residual disease left behind. Coming to end treatment response. Next slide. This was a case of NHL after treatment, full treatment. We can see that the left panel showing an extensive disease involving nodes right from neck to the inguinal plus a lot of marrow disease, and on the right panel showing the complete response of all the lesions in all the lesions. Next slide, please. This was a case of NHL after post chemotherapy. Now this is very interesting. You can see that after pre-treatment there were big nodes, axillary nodes. There was splenic lesions which were quite positive on PET, but after the treatment the nodes have regressed, the spleen lesion have vanished, but the axillary node is still quite big node. And but because there is no PET uptake, we can definitely say that this is complete metabolic response. It would fall in the category of Dewey's 2 score, saying that this is a complete metabolic response, and whatever is is remaining is just a post-treatment morphologic residue and not a residual viable disease. Next slide, please. Next slide. This was an operated carcinoma breast post chemo and radiation. Pre-treatment, USG showed some multiple liver lesions, but on the PET scan, there was nothing. Absolutely nothing in the whole body imaging, saying that the patient is in remission. Next slide. This was a case of NHL after chemotherapy came for response assessment. Next slide. You can see there was a big mediastinal mass and a small node, mediastinal node. Now the lower panel is showing that there is complete metabolic response, but there is a small residue which is remaining in the mediastinum, though it is not metabolically active. I mean, it is suggestive of a complete metabolic response. Next slide, please. This patient came to us after 6 cycles of chemotherapy, a case of Hodgkin's lymphoma. The patient had a mediastinal mass. On the PET scan, there is a small soft tissue in the right side of the mediastinum pointing to where the arrows are pointing, but there is no uptake, which is indicative of a complete metabolic response to treatment. However, there was one focus which was in the prevascular space, which needed a follow-up, and on follow-up, this patient showed that even that focus had vanished. Next slide, please. Next slide. This was a carcinoma lung with bilateral adrenal choroidal metastasis after chemotherapy and radiation to the eyes, followed by again chemotherapy for response assessment. Here on the response, we could pick up that there is an increase in the PET uptake, but the size-wise, the lesions had not changed much. But definitely there was a definite increase in the PET uptake and the SUV values, which pointed towards metabolic disease progression. Coming to the next evaluation is inappropriate evaluation. This was a case of CA ovary who presented with brain metastasis. The patient underwent chemotherapy and a neoadjuvant chemotherapy, but and came then for a PET scan to see if there is any response. Now the catch point here is that it was a case of CA ovary directly metastasizing to the brain, but there was hardly any pre-treatment evaluation done for the lungs. And what we picked up was multiple bilateral lung metastasis as well as skeletal metastasis. Now we are unsure. Can you please go back? Now it is very unsure whether these lesions were there before or if they had they are a new finding developed in between during the treatment. Now we cannot stage this disease accurately, but as far as PET CT is concerned, I can only summarize that it's a metastatic ovary with brain mets, lung, and skeletal mets. But I cannot assess accurately the response here. Next slide, please. What is there a role in biochemical recurrence in PET scan? Next slide. This is just to highlight that this is a case of CA prostate after orchidectomy and on hormonal therapy. The patient had developed there was active lesions in the prostate. Next slide. Involving the seminal vesicles. So there was definitely there is a big role when you have cases where the patient is on a follow-up with tumor marker levels, and if there is any deviation in the tumor markers levels then the expected route, then a PET scan is the modality of choice. This is another case to highlight the same thing. It was a CA ovary with raised CA 125 levels. Patient came to us and we could pick up that the disease which was there before, it has progressed further. Next slide, please. Role of PET in unknown primary. Next slide. This was a case presented with left leg cellulitis. Doppler was done, and which revealed there was a left inguinal node. A biopsy showed. Next slide. Biopsy showed that node to be a squamous cell, metastatic squamous cell carcinoma. A whole body PET scan showed that the lesion was in the foot. Next slide, please. This was a very interesting case. A 81-year-old gentleman who came with history of diarrhea. A CT scan showed cholecystitis. There were bilateral lung nodules, but there was the CT scan had impressed that this might be a case of primary gallbladder, and a whole body PET scan was done in this case, which the PET scan showed that the gallbladder was just showing some mild diffuse uptake consistent with cholecystitis and not carcinoma gallbladder. There were multiple bilateral lung nodules. Next slide. But what we picked up on the PET scan was a lesion in the prostate. Serum PSA was surprisingly normal. I recommended a prostatic biopsy, which came out as adenocarcinoma with neuroendocrine differentiation, which is a high-grade prostate, and it confirmed that the metastatic lung nodules were from prostate. This is a case presented with a loss of consciousness, CT brain showing space-occupying lesion. Next slide. There were multiple nodes and lung nodules. Next slide. But there was a small lesion in the rectum, which we impressed that this might be, because there was no other primary elsewhere, we tried to impress that this might be a case of carcinoma rectum with extensive metastasis. Next slide, please. This was a case of solitary pulmonary nodule incidentally detected. A PET scan was done just to see if we can pick up a primary, and what we picked up. Next slide. A PET positive nodule, which was already known. Next slide. And a nodule, PET positive nodule in the thyroid. The biopsy showed that this was a papillary carcinoma thyroid with metastasis to lung. Next slide, please. Now, this is a very infrequent indication, but very important indication where after early treatment completion, I usually tell my referring doctors to have an annual follow-up with whole body PET scan, at least for first 5 years, so that we can pick up early disease before the patient becomes symptomatic and can be offered a radical cure. This was a CA breast post-op, post-chemotherapy, and after CyberKnife radiosurgery for liver metastasis. In 2015, patient was followed up in 16 and 17. The patient was perfectly normal. So it gives an overview of a whole body where you don't have to undergo any other evaluation, and the patient can be easily followed up with a good comparison with the previous scan. Next slide, please. Coming to problem areas, we all know that a lump or lesion may not always be a cancer. It can be a fibroadenoma, lipoma, myolipoma, cyst, or even an hemangioma. Next slide. To highlight this is an example of a CA lung. Next slide. This is a lung mass which is positive on PET, definitely metastatic. On the right panel, there is a nodule in the breast which is not PET positive and definitely a benign lesion. This is how we usually differentiate, and we are almost, I would say, 95% accurate in distinguishing benign versus malignant lesions based on PET scan uptake. Again, another example to highlight the same thing. This is a liver SOL, PET positive on the left panel, definitely metastatic. This is a carcinoma breast. Imagine the patient has come for a follow-up with a liver SOL and we are picking up the metastasis. While on the right panel, there is a CA esophagus case who's come for a staging with a liver SOL, and it is not showing, or it is devoid of any FDG uptake, suggesting that this is definitely a benign lesion. This is a case of right glioma, which was not treated and now presented with 2 lesions in the brain and a left lung mass, which you can see. And next slide, please. The lung mass was please go back. Thank you so much. The lung mass was not FDG positive, not PET positive. And we reported that this is not a primary lung mass, but these are primary intracranial gliomas. And the lung mass we reported as hematoma. And the patient turned out that way. Thank you so much. Next slide. Second problem areas is after cancer treatment, we know usually the size will shrink, or if on the PET scan the uptake will reduce. But we also know that even if the size may not shrink, the lesion may be dead. And even if the size shrinks, the lesion can still be alive. Next slide. This is an example to highlight that even after treatment, after chemotherapy, a lung mass, though it has regressed in size, it is showing significant residual disease. Next slide, please. I'll skip the non-oncological indications because I think because of shortage of time, I would just skip this. Just yes. Thank you, Doctor. Just go back to this slide, previous slide, Dr. Olole. One more. No, next slide, please. Next slide. I think next slide. Next slide. Yes, just hold on. Just previous slide, please. One more. Yeah. Now this is a data taken from the NOPR, National Oncological PET Registry. Now this shows the impact of PET CT that is seen on various indications. You can make out that in the initial staging, it changes the management in around 40% of the cases, in restaging around 36%, in suspected recurrence around 38%, in diagnosing a cancer around 25%, in carcinoma unknown primary around 43%. This slide shows you that after the PET was done, there was no need for any further evaluation to be done, especially in diagnosing a cancer or in unknown primaries, or even in detection of paraneoplastic syndrome. You can see that 70% of the patient just did not need any further evaluation. So the take-home message from is that the whole body PET CT plays a significant role in cancer evaluation, and the cancer evaluation is incomplete without PET CT. It is also extremely cost effective. It can be used as a one-stop evaluation and should not be excluded from cancer workup. Also, it plays an important role in non-oncological indications and like neurodegenerative disorders, seizures, dementia, which I haven't touched upon because of time constraints. Next slide. With that all, I thank you everyone for the patient listening. Hope this was very informative. And if there are any questions, I would be glad to answer those. Thank you so much.
Wow. Dr. Sanchez, you have taken us on a grand ride to the world, into the world of PET, from both diagnosis to the role in recurrence, to the role in identifying the possibilities of treatment, and even the changes that PET, which we all know is a game changer into the world of management of oncological cases. And I must really say that we're very privileged to have a national and even international audience who are going to be getting their response on their questions right now. So we have a few questions, and I see a few hands are already raised. We'll take from the question and answers. We have Yannick from, it says, one of the most important aspects of delivering healthcare is the cost implication, as affordability is a major factor that influences whether a patient can be able to get treatment or not. What is the cost for an average PET CT of the brain and the heart? The marketing team, hope you are taking note of that question, which I think is going to be a recurring question. So if you could quickly dispense of that now, we can move to other questions. Thank you.
Yeah, good afternoon, everyone. Good afternoon, our moderator.
Good afternoon.
Yes, sir. The cost for a PET CT scan, whole body PET CT scan, currently is 495,000, sir.
Okay, 495,000 per scan. That's about 500,000 per scan. So please let's be aware. We can also, someone can help us type it in the chat box so that that will not be a recurring question. Then the second question goes thus. It says that, what is the maximum tumor or lesion size that the PET CT can detect? Dr. Rumui, I think you will help us with that.
Thank you so much. In terms of maximum size, the PET is a whole body imaging modality. So maximum size does not matter. No matter how large the size is, as long as it's within the field of view, it will be detected, because the tumor, now it will just show the heterogeneity of the tumor. Heterogeneity means a tumor can have multiple parts. Even though it's primary breast cancer, it can have some receptor expression. It might have different grades, different aggressiveness, different growth rates. So I guess you might find heterogeneous uptake in some tumors and find homogeneous uptake, that's uniform uptake in some tumors. But in terms of large size, any size of tumor will be detected on PET. And just to add a rejoinder to the cost of PET CT, the cost is initial cost heavy, might appear to compete with other costs. But in terms of the cost effectiveness, when PET minimizes the need for other tests or other treatments, like when Sachin was showing us several cases of patients who had residual morphologic disease, like lymph node disease, but it was metabolically inactive. Sometimes those patients will go on to have radiotherapy that is not necessary, and the PET would have saved them that extra cost, both financial cost and then biological cost in terms of side effects from other treatments. So let us not look at the costs alone, but look at the benefit of those costs long term. And I think if you look at it from that perspective, we now start having discussions on how to make PET more affordable, either by way of health insurance or other support mechanisms to reduce the cost from the providers. Thank you.
Thank you very much, Dr. Rumi. And there's another question here that's from Dr. Uyi Usoro, who says that, can one get the recorded version? I am very sure that Mikio and our marketing team will post a recorded version on the website so that, for example, we know that there might be some of our colleagues who are busy right now attending to patients who will find the lecture series very, very important and useful as we go on. Dr. Long John, I greet you specially. Yes, I know that there's some hands raised. I just want to go through the chat box before we take those ones so that we'll have finished with the chat box, then we'll go to the hands that are raised. We recognize the team from Sokoto. We see the team from KB. We are grateful that you are able to join us. We recognize also the team for Aminu Kano Teaching Hospital. You have done very well by joining us. Also, we will accept all the appreciation terms. And for the CME point, I'm also aware that this webinar comes with, I think, about 5 CME points. So for Medicine Man Worldwide. Then also someone asked for the indications of the PETs. The indications will be shared also is on the lectures, but it will be shared also on the site. I think that's about all we have now. Let's see the new message. It says great lecture, the indications. Yes, now we can go to the hands that are raised. We have, I think we have 2 hands raised. Someone raised their hands earlier, but let's start with Dr. Yunusa. Dr. Garba Yunusa, if you can we please unmute Dr. Garba Yunusa for him to speak to us?
Yes, done. She can talk now.
Dr. Yunusa, please, you can have the floor while we are preparing to talk about Dr. Appreciate especially. Yes, okay. Please, go ahead, Dr. Yunusa.
All right. Good afternoon. Can you all hear me? Once
yes,
again,
you are very audible, sir.
Yes, my name is Garba Yunusa. I'm a nuclear medicine physician and a radiologist as well, and the head of nuclear medicine in Sokoto here. I will first of all congratulate Mikio for this wonderful achievement, for being the first to bring this kind of equipment that's much needed by our population, by our patients, and also, of course, the clinicians. Just to slightly highlight some other things that were well discussed by Dr. Sachin and Dr. Durojaye, and also Dr. Akin. Clearly, with the examples that we've seen today, we know that PET-CT has a very important role in management of cancer patients. Clearly, we've seen from the images shown by Dr. Sachin that now PET-CT forms part and parcel of treatment of patients with lymphoma because it plays a key role in accurate staging of patients, restaging them, and even determining treatment, assessing treatment response So clearly, so that early in the disease, you can either know that yes, your chemo is working, or your chemo is not working, and you can switch to another line of chemotherapy. So it helps very well in getting a very good outcome in patients with lymphoma. Clearly also, to highlight some other indications, cancer of unknown origin. You can see from the examples demonstrated by Dr. Sachin that yes, where there are dilemma, there are concerns that yes, there is a cancer elsewhere, and we don't know where it is, you can easily use imaging modality. So in the light of cost effectiveness, you can see that PET-CT comes in always very handy, of course, in helping you to localize where your tumor is, and then biopsying, and then having the histological diagnosis and moving on, going further with surgery or therapy. Then fever, pyrexia of unknown origin. PET-CT also helps. Sometimes anatomic imaging may be very difficult in localizing where the collection is, where focus of infection is. But PET-CT helps you actually in localizing, and then you can go further to actually do biopsy and then culture. Sometimes, yes, blood culture might reveal evidence of infection, but locating where the focus is might be difficult. So PET-CT comes in very handy in that respect. Also, I would like to also use the opportunity to now encourage MIKIO to actually establish a very good network of communication with the referring clinicians, because clearly you can see that the patients that are being referred for PET-CT need adequate preparation. So therefore, that link or channel of communication between the PET-CT center and the referring clinician is very, very important, so that we can get the best out of the examination that we're going to do. Of course, the referring center, the PET-CT center would need to know, is the patient diabetic? What kind of treatment is he on? Has the patient had surgery? When was the surgery? Is the patient on chemotherapy? When was it done? So that the patient will be referred appropriately and also at the right time with the right information. In fact, then as much as possible, get as much as possible imaging that was done, previous imaging that was done, because that helps in the interpretation of the examination. Tumor markers that were done, histological diagnosis, all these are very useful. So please, MIKIO, establish that link between the referring clinicians and the center, so that you can get the best out of the examination. And then finally, also, I would like to encourage MIKIO to, since they've done this difficult part, they've done the most difficult job actually, they can go further, because PET-CT has a lot of uses, none other oncological uses. And even in oncological uses, you can go further to now acquire the germanium gallium-68 generator, so that you can get your gallium-68 for PETs, for gallium-68 DOTATOC and PSMA imaging. This will help you. It's going to be the gateway of now bringing in treatment for some of the cancers that require treatment. Prostate, for example, can image and treat in this environment. Image with gallium-68 and treat with lutetium-177. Neuroendocrine tumors, you can image with the gallium-68 and then treat with the lutetium. So please go ahead, MIKIO, and get these facilities, and then the sky will be the limit. Our patients will be happy. You're doing that. I also congratulate you once again, and also thank the presenters, as well as my friend, Dr. K. Thank you very much.
Thank you very much, Dr. Yunusa. I must mention at this point that Dr. Yunusa was very warm towards us when he visited us in Pretoria while our training was ongoing. He was coming from Cape Town to share some very brotherly time with us, and also encouraged us that someday this thing that's happening today was definitely going to happen, that we should not lose steam from the fact that we were being trained at that time, and we're taking a peep at home, and there was no infrastructure. Dr. Yunusa, they are really very, very of the questions now. Someone said, can we get PET-CT scan in Abuja? Presently, PET-CT scan is only available at the MIKIO Center on Nitel Road in Oshodi, Lagos. And then please, let's take note of that. How much is PET at MIKIO? The whole body scan is 495. And it also includes, it's a one size fits all, includes also the pre-screening scan. It includes the PET itself, the CT itself, and also the scout scan that normally would be done. Someone has asked what the regional studies will be for. I think the regional studies will be, the price for the regional studies, the marketing team should please be ready to communicate that with us. Then someone mentioned, how do we send referrals at Mikio? There are contact numbers that will be displayed. The marketing team should please also avail us. They should share the contact numbers and the email addresses via which they can send referrals in the chat box and the question and answer box so that people can pick it from there. Thank you very much, Dr. Yunusa, because you know we see that the price for success is more hard work, and I'm very sure the brains behind this success and this landmark achievement in Nigeria are ready and are willing to also take up that demand, such that while we have identified cases, particularly nutrition care setting, we would also be able to treat within these confines, and also have other generators that will be useful. Someone mentioned that can we have, I think someone was trying to say whether they can have in Abuja. We only have it in Lagos right now. I don't know if Anthony, marketing, do you want to say something concerning the regional cost? While we're still waiting for Anthony, I don't know if any of the speakers would like to mention anything about the questions. Dr. Sanchi, is there anything you'd like to add to what has been going on?
Yeah, I think it was a very enlightening session. The opening remarks from Dr. Akin, and then nice case discussions, case presentation from Dr. Aduja. Right now, I would say that you guys have just started, so just focus on doing good quality work. Certain procedural standardizations, protocols need to be set up for different cancers. I'm sure Dr. Akin is aware about it. I think other than that, there is nothing as of now. And Dr. I forgot, just lost his name, the one who mentioned about the gallium generators.
Yeah, Dr.
Yes.
Garba.
I'll just touch upon that gallium generators right now are they look very fascinating, and they are also rewarding, but they are only limited to prostate and neuroendocrine cancers. But yes, we are going to see a revolution in PET. When Dr. Akin touched upon that, there is some new molecule which is just waiting to get launched called FAPI, which is a gallium-based generator radiopharmaceutical, which will completely change the dynamics of PET imaging in the future. But as of now, all the best to Meteor. I just hope that you guys do phenomenally well. Once again, congratulations and all the best to you.
Thank you very much, Dr. Sanchez. I'm very sure that the caliber and the quality of audience that we have speaks volumes to the fact that these are the decision makers and heads of institutions, heads of nuclear medicine and PET-CT departments who are going to be taking decisions concerning this management. I don't know if marketing has any housekeeping. If you would like to have information in your email, you can please drop your email address in the chat box so that the marketing can pick it up from there and share a direct mails with you. So if you would like to have information concerning, but I think they should, marketing should please, while this presentation is still on, as we begin to wrap up, please include the contact email and contact numbers for MICURE. Please include it, and people that would like also should please share their email addresses with us so that we can make a direct connection, and we can also have a very good communication line with each and every one of our people. Dr. Yari, I see you, and I greet you specially. Thank you for joining us all the way from Southeast. Dr. London from the South of the nation.
One hand is raised.
One hand is raised. They can speak. Dr.
Okay, the hand is raised. Who's that?
Dr. Odinaya.
Professor Quero.
Okay, Prof. Prof, please, you have the floor now, sir.
Dr. Odinaya.
Thank you for those that are dropping their email addresses. Dr. Ogu, we are very grateful. Dr. Samuel, we've seen yours. Dr. Yari, Director, we are grateful. We've seen your email address. Victoria Alabi, we've gotten yours as well. Anybody that would like to talk before we, the marketing, have you decided about the regional scans? Can someone get Anthony to give us information?
Quickly, I would just say a few things on the process of registration and also share a contact number for proper follow-up, sir. We'll make the process of registration seamless for doctors, patient. So what we need to do is just visit www.micure.com.ng and proceed to click PET-CT. Then the patient fill the form, automatically that takes us to another page where the doc PET-CT registration question.
Did we lose him, or is it just me?
I think we lost him.
Yeah, I think the connection was lost.
Okay, while we're waiting for him, I greet Professor Tajudeen Olasende. Prof, we want to greet you specially. Is from, I think that should be ABU Zaria in Kaduna. And Prof, we are grateful that you found time to join us. Also, I want to greet Professor Rukudade. He was in the UK and he had to join us from there. Thank you, Profs, and all the other professors and our leaders and teachers who have found time of their very busy schedule to join us. I see Dr. Adeomi Alabi. She is also on the line. Thank you very much, Dr. Alabi. Tokumbo Ojubolamo, Tawakali to Ayuba, and the over 100 participants here. I may not be able to go through all the names. If you check the chat box right now, the PET-CT, how to navigate has been shared. The link, so you could copy the link from the chat box right now. Dr. Follow Kuala, we also recognize you. I think Anthony is back. Anthony, are you back now?
The cancer inquiry form, that is the process for the registration for the PET CT scan. When that is filled by default, we'll receive it. And also what patient need to attach, the investigation and test done by patient will also be attached along that form. So we receive that by default, even before they come for the testing. Also, I'll also be sharing my phone contact for further follow-up with patients and doctors.
Thank you very
the
much.
Contact numbers are 080.
Please put it in the chat box, sir.
Beautiful.
Put it in the
I'll do
chat
that
box,
right away, sir. Thank you, sir. Thank you, sir. Yeah. All
On
right, sir.
behalf of
Thank you, sir. Yeah.
I would like us to begin to round off. We want to appreciate all our speakers. We want to appreciate Dr. Sanchin. He's 4 hours ahead, he's in Mumbai. We want to appreciate Dr. Trudaya Deluja. We want to appreciate Dr. Olumwe. We want to appreciate the management of MICURE for giving us this awesome opportunity and platform. I want to especially appreciate Anthony Gnedion for handling the marketing side. Samuel, I want to thank you especially. And I want to say to the men working behind the screen to ensure that this is a success, and to all our attendees, we are indeed very grateful. Thank you very much, and we hope to get your referrals, and we guarantee you that we'll do our best to give you quality service and to make sure that this groundbreaking innovation has come to stay in the country. Thank you very much, everyone. Have a wonderful day. Bye-bye.
Thank you so much. Bye-bye.
Thank you very much, sir.